Welcome back to our fifth discussion on cardiac surgical arrests. I'm once again joined by our fabulous panel of experts, Christina Ruiz, John Whitlock, and Tara Bartley, and we are here this time to discuss how we manage left ventricular failure. This will fall under the PEA scenario, and I find this one rather challenging because basically you determine that you've got a patient in a low output state, and then you need to determine the specific cause of impaired contractility. And that could be LV failure, tamponade, acute ischemia, or valve failure. So I wanted to start with Tara. The hallmark presentation for all of these conditions of impaired contractility would include hypotension, elevated filling pressures, maybe some compensatory tachycardia, and I think it can be a challenging diagnosis to make. What suggestions do you have for clinicians to help them differentiate this when they're in that low contractility diagnosis? How can they, quickly make that diagnosis? Are there any tips or tools that you use that would help others?
Thank you, Jill, and hello to everybody. I personally have benefited, I think, from using what we call the 5-point plan, which is advocated within the CALS system. The 5-point plan identifying what the problem is. And when you first look, you need to sort of establish you're dealing with a preload, a post afterload, or a contractility problem, as you said. So I then home that down into preload. Is it due to hypotension from bleeding or hypotension from lack of filling? And in that case, you can look at your central venous pressure, and you can look at where you think you are from a fluid management point of view, and you can look at the bleeding. And in every case, the patient will be cold. From the post-pump problem, in terms of looking at afterload, you're trying to establish if you've got a dilated patient through normal rewarming, through any sort of anatomical failure of any point, but also whether or not you've got any signs of infection. So I think the timing of when you establish that is important. If it's within the first day or two, it's not likely to be an infective cause. And there, what you can do is you can have a look again what the CVP is doing. Both of those incidences, you will have hypotension and probably increased contractility in terms of heart rate. But the temperature of the patient and the CVP will be the determinant as to whether or not you've got a preload or a post-aftercare post-load. And then the other cause that we can have is something to do with contractility or the heart itself. So if you're going to have a look at the pump, what can go wrong with the pump? So the things that go wrong with the pump, as you alluded to earlier, are an arrhythmia, an ischemic issue, or in actual fact, a problem with the valve, or is it just a problem with contractility because the heart is unable to respond appropriately? So is there a tamponade going on? So I think if you have that approach and you go to your patient and you run through that in a systematic way, you can have a look at what you think your diagnosis is, what your immediate action plan is, what you think your actual diagnosis is compared to the other differentials. Is the patient hot? Is the patient cold? It's channeling me towards one or other of these diagnoses. And then what you can do from there is you can then have a look at what investigations you need to confirm that. So what parameters have you got in terms of everything that's there in terms of lines and monitoring? And in fact, do you need anything else? Do you need further imaging such as an echo or other imaging or other blood tests in terms of coag, etc.? So then you can reevaluate, you can confirm whether you think you're dealing with a pre-pump, post-pump or pump problem, and you can start to go down your treat management plan.
Thank you. I mean, I think that's, a really nice synopsis of that, 5-point plan lecture. That was a very nice approach to this. John, do you have anything else to add besides this sort of, universal process of elimination and really thoughtfully working through all the things that it could be?
Just excuse me, reinforcing Tara's mentioning of the 5-point plan. Germane to the protocols is quick identification of what a problem is, and don't be afraid to take a guess, an educated guess at what's wrong. For instance, in this case, we're talking about hypotension that could be from bleeding or hypovolemia or preload problem, or an LV problem with the LV. And if we don't have obvious signs of bleeding, then I kind of check that off. If the patient's CVP doesn't seem to be too low, then I kind of start to look closer at the hemodynamics. And if the patient is having low cardiac output, low cardiac index in the setting of hypotension, and with a rising PAD, I think we are pretty much on the road in the right direction.
Thank you very much. Are you getting a lot of echoes? Is that something that you can get easily at your facility?
We do, absolutely. We tend to get echoes more if we really feel like there's a blood collection around the back of the heart.
Okay. Yeah.
Honestly, if we have those hemodynamics to support a decision, we would probably start there and then add an inotrope and see if it made a difference.
Thank you. Christina, do you have a set kind of
Yeah.
protocol for managing the diagnosis of LV dysfunction or low cardiac output state, or how might you manage this at your center?
So I will echo what Tara said. I mean, and what she said is being systematic on what you're doing. So really is reassessing yourself, and it's kind of following this ABC, this tool that is just gathering information and learning more about your patient. Really, is it what we are, who is this, and what's wrong in here. So it's a bit of an investigation process, but without forgetting anything. I agree with John with the tool Echo. Echo is an amazing tool that we probably not use as much as we should, but it's there. And I think in ITU, even on the ward, is a tool that more and more people spend time in learning. So I think it's easier to use, it's available most of the time, and it's quick gel on, and it gives you a lot of information about the patient. So that probably will be the tool that I will say it's easy there, just use it. And then it gives you a lot of information, especially with the contractility of the heart. And then it guides you quickly where you need to go. So it's this 5-point plans that Tara was saying, and that could be one of them. Quickly, just do anything, give you a lot of information.
Yeah.
What I would say is just add, is it nursing, they don't tend to get during training this ABC, this systematic kind of learning. And I think CALS introduce you into this resource as well when you're doing resuscitation, but it's more in CALS, this systematic approach to diagnose and treatment, which is, I think it's nurses, they not use, and it takes quite a lot of time to get into this process, but I think it's really good, especially when you're doing CALS.
I think that is one of the most helpful lectures that we teach, is basically just using that analytical approach. And as I always mention, there are a finite number of causes that can get your patient into trouble like this. And so you really can go through that process of elimination, oftentimes ruling certain things out. As Tara said, it's not a preload issue, their filling pressures are high, etc. So thank you very much. I mean, I don't think it's a cookie cutter thing, but I think all of us are saying the same things. Get to the diagnosis as quickly as you can. So now you've made the diagnosis and you understand that this is a patient that's got left ventricular dysfunction. John, we've got all these medications at our disposal now. I'm curious, do you have a set protocol if a post-op patient is having LV dysfunction? One, does a heart failure team get brought in immediately? Does your surgeon forge ahead? And is there a set sort of medication that you kind of always go to first?
Yeah, this is a little harder to tease out in terms of, I don't know that we have a protocol that we follow, because generally once we get in this place, it's a very individualized problem. I will say in general, I found the practice to have a lower threshold for mechanical circulatory support. There is a body of knowledge out there now that it really supports the concept that use of inotropes and vasopressors can create stress on an already sick heart, and that mechanical support is truly unloading and helping provide end organ perfusion without stressing the heart. So I would say that it's not protocolized, but I do see we have a lower threshold for putting devices in. In most cases, though, we will start with some medication to try to bridge us through until we make that decision to move forward with a device. And in some patients, that's going to mean trying to just unload, and then other patients will add an inotrope.
Got it. Yeah, I think it's very unique. Tara, are you seeing the same thing in your organization? Is there a set protocol for management of acute LV failure?
I mean, I think that's unit driven and surgeon specific to some extent. Some of it's environmental and sort of what is available. You know, are you looking after a patient in a transplant center where devices beyond an intra-aortic balloon pump are easily available or not? What I would say is go back to basics, get the basic things right. So you need to establish, was this a pre-existing issue pre-operatively? Have we exacerbated it, or is it new finding? You then want to make sure that you've got your very basic sort of recovery right in terms of trying to reverse any acidotic state in the patient, make sure that they're the right temperature, ensure that you've got the correct fluid sort of, balance between not too much in, not too much, not enough in. Was there an ischemic event intraoperatively? Was there something about the anesthesiology that was, that has driven an event of some sorts? Has the patient had a pulmonary embolism? You need to exclude all those issues. And then what you're going to do is have a look, you're going to use your pathophysiology about Frank Starling's law, and you're going to look to see whether or not you want pharmacology or whether you want mechanical intervention. It's quite helpful, isn't it? We're all quite fortunate these days in our technology to work out whether, as we said, we're dealing with a preload or an afterload or a pump problem. And so we're trying to work out if we need to offload. And also, I think it's important to discern between the left ventricular failure and any existing or exacerbated right ventricular failure. So that will guide you in your inotropic selection between sort of your dobutamine and epinephrine, and perhaps adding in milrinone in terms of your phospho aims for inhibiting and relaxing the sort of the cardiac muscle. Or in actual fact, are you wanting a vasopressor such as noradrenaline and to reduce offload in that sense as well? So I would say perhaps our threshold for mechanical devices is maybe not on the same par as John has mentioned. I think an intraoperative balloon pump is often put in electively in centres across the UK because there is an anticipation of failure problems, and the idea of resting the heart post-operatively and having a more controlled situation is advocated. Then, if not, the balloon pump will probably be put in intraoperatively at the end if you're struggling to get off of bypass, etc. I don't see very many being put in post-operatively, which I suppose is a positive, really. However, in terms of that sort of escalation to other devices, in terms of LVADs, ECMO, etc., which I think we'll probably come on to shortly, is something that, that trajectory needs to be looked at carefully, and the level of expertise as well in that area, really. And then we'll get to transplants.
Hopefully we're not there yet. Yeah, I'm definitely seeing that, when the program first came out and I learned it, there weren't specific medications that were advocated necessarily because they really are all over the map. And I think there's a lot of variety in what medications are used. There may be some center specific preferences along those lines. Christina, how would your team manage a patient that presents with acute LV failure postoperatively? I
think it's not different from John and Tara, and I think it's more similar to Tara because we are in the same country. But I think it depends a lot on the center that you work and the resources that you have in the center, because the small centers like mine, we don't have ECMO, we don't have access to mechanical devices. So we have to really understand our patient. We really need to prep our patient. So MDT, multidisciplinary discussions before, and maybe contact other centers if we think that the case is going to end up needing extra support. So then we need to be conscious that we won't be able to do that. So we need to refer the patient to another center. So I think preparation, if you can, if it's an elective patient, is essential. If you run in trouble, then yes, we've got balloon pumps, we've got drugs, we've got milrinone, we've got inotropes. But I think that will depend on the situation and on the patient. But I think if you have a clear understanding of your patient before, and if the patient LV contractility, there is a problem after, then we need to look in the causes. Like Tara said, why we here, why the LV is not working. But yes, I think small centers or centers that they don't have the capacity to have those devices, they really need to discuss the patient before.
That's an excellent point. I mean, really knowing what you're getting into, and you know, occasionally a patient coming back from the operating room that went into the OR with a good ventricular function, coming out with poor ventricular function, you really have to stop and ask what kind of technical misadventure has gone on that led to that. Tara, were you going to say something there?
Jill, I have a quick question for Christina and Tara. At my center, it's routine to get an echo pre-op and post-operatively, and that is part of the handoff when the patient arrives in the ICU. Is the same true in the UK?
From my point of view,
sorry, Tara, go for it.
Okay. From my point of view, nationally, there is a huge issue around access to echo, and that is because we have a national shortage of technicians being able to use, to deliver that service. So I think in the centres that I'm aware of across the country, it is quite challenging to get a post-op standard echo. So yes, preoperatively, you will either have an LV gram on your angiogram, or you will have a pre-op echo, depending what the primary pathology is that you're doing, whether it's valve or whether it's grafts, etc. In terms of post-operatively, then we will either look to get no echo or an echo post-operatively as an inpatient, particularly if we've done some mitral surgery, or in a routine sort of case, albeit a valve as well, then we may well get the echo prior to the outpatient's appointment, which tends to be 6 to 8 weeks post-operatively. That's in a routine case. In a case where things aren't going well, then you will either ask for an echo to be done in an urgent situation, and that'll either be done by the cardiologist, or in some centres across the UK, ACPs, advanced practitioners, are able to perform an echo to just have a look to see if there's an acute problem. We had one the other day. We had a quick look to see the RV failure, and there was a posterior clot, and that helped inform us the decision as to whether to take someone with very fibrable tissue back to theatres or not, and whether we think the clot actually, risk versus sort of side of things, whether the clot will dissipate in its own accord and the patient's dynamics will hold while that happens. So we can do that in emergency, and we can get a routine one where you go down to the department if needs be, but obviously that's only suitable for the stable patient. So Christina, I don't know what your thoughts are.
No, I was going to say that we on a valve patient, we always do an intra-op. So it's always an intra-op echo, so you can check everything that is going correctly at that point, and then you can have your post-op echo later on. But at least you have a bit of understanding. So every single valve patient, and I'm pretty sure everywhere in the country and most other places, even in Europe, they have an intra-op echo to confirm that the valve is in the right position and is working well before the patient leaves the theatre. So that gives you quite a lot of information. If from them, then the heart doesn't respond, then in ITU, you always have access to, again, a TOE or an echo. Post-op echo can be done later on. We don't have the problem that we struggle sometimes, but it's not that bad. We can manage to do echoes before patients leave the hospital post-op, but we only do it on the valve patients. We don't do it routinely on the coronaries. So.
But if you were worried, you said that you've had a couple of reopenings since we've filmed last.
I know.
Either of those patients, could you do your own echo? Could you just put some gel on and take a look?
Yeah.
Okay.
And I think the other thing just to say, and actually I thank you, Christina, because I didn't allude to that. So if intraoperatively, a patient will often have a toe in position, and that will inform the process, particularly as Christina says, in valve surgery, for what is happening. And I would very much expect to see post-operative noting of whether a valve was well seated, whether there was any paravalvular leak, etc., and a note of if there was any problem with function. And the patient I alluded to earlier, you know, we did actually do a toe first thing in the morning. So if they're still ventilated, it's a much easier thing, you know, to perform as well. So.
And I think if you got a patient with a non-heart failure who is going for surgery, then most people will do a TOE in theatre as well to kind of have a quick look and see things. So you keep the TOE in place until the end, so you can reassess things.
Mm-hmm.
And I was just going to say, for those of us from the States, TOE is transesophageal echo, esophageal with an O. So just wanted to make sure we were all aware of that.
Oh yeah, please. We keep saying all this TOE, TTE, and we forgot these different countries.
About our international conversation, we can make sure we're all speaking the same language.
So we should probably reiterate that when I was talking earlier, we were talking what we call a TTE, which is transthoracic. So just literally put the gel on and look to see if you want a 2 or 4 view, etc. And then you can make an assessment. But actually, the transesophageal echo is kind of the gold standard baseline when we are looking preoperatively, intraoperatively, or postoperatively if we have some concerns, or if we are just looking for information to outline what it is we want to do from a surgical perspective.
Yeah, fantastic tool. Really has changed a lot in the decade that I've been practicing. Christina, we are seeing more patients with right ventricular dysfunction. Tara alluded one situation may be a patient's got clot behind the RV, lots of other conditions. Are you seeing this, and are you, in your classes and things now talking about differentiating right ventricular dysfunction from left ventricular dysfunction, or are we still all kind of managing ventricular failure as kind of one bucket?
Oh, no.
I didn't think so. I'm setting you
Good
up.
answer.
No, they are completely different things. The problem is in my center, we tend not to see right side failure because this is the patients, unless it's something suddenly that happened and in a situation post-op and we don't know, but we don't tend to get those complex patients because, as I said, these patients, they won't come to my center. They will go to a more specialized center with facilities that they can be put on an ECMO, or so probably Tara or John, probably they'll have better answers. But on a classroom, when you need to explain things, they're totally different situations, and right side failure, I will say it's more complicated to get out than a left side failure. So, but I'm sure Tara and John will have more discussion on that topic than me.
Thank you. John, I'll go ahead and have you answer next. Are you seeing many patients with right ventricular failure, and is that something you're now including in your classes to help your nurses make that diagnosis?
Not as a standalone diagnosis, Jill. More often we are looking for right heart failure, particularly in our heart transplant patients. Since we started doing heart transplants, we've learned that RV failure could be, it typically is one of the earliest signs of graft failure. So we are hovering over that RV function constantly. Interestingly, our transplant surgeon prefers that all those patients come out on low dose is possible, but on some dose of epinephrine for its both inotropic effect, and it creates a tachycardia that we feel can help with overfilling of the right ventricle by speeding the heart rate up. We also use our pacing wires to keep a heart rate of as high as 120 as a standard.
Interesting.
And
Yeah.
that transplant program patient has really was the first time it elevated everyone's knowledge in the unit about what RV failure looks like and how to prevent it.
Thank you. I think you're absolutely right. That population is very vulnerable for this problem. Tara, so you mentioned a patient who had clot behind their RV. Is this something, again, are you seeing a lot of right ventricular dysfunction, and how are you managing that?
So that's a really interesting question, isn't it? Are we seeing more or are we identifying more?
Yep.
So, and I would argue that it's probably a combination of both. I mean, we need to look at pre-existing conditions, and people are coming to surgery with pre-existing conditions that may well not have rendered them suitable for surgery in years gone by. So, you know, we see more pulmonary hypertension these days, the prevalence of AF, all of these things will lead towards a degree of right ventricular failure if they've been there over a sustained period of time. So in those instances, I think if we've got good documented evidence, then we are considering preoperative lever cemending infusions in some organizations, just to sort of increase the calcium sensitivity and to be able to sort of ensure that the patient's optimize prior to going to theatres. And you probably want to start that sort of 24, 48 hours ahead of time in a controlled situation. For the intraoperative and post-operative patient with new RV dysfunction or RV dysfunction that's perhaps been exacerbated, you know, we need to think of what are the causative factors. We know bypass will have a possible impact on that. We know the possibility of thrombus will have an impact. We think about sort of the insult to the myocardium in terms of what that might do and the underlying pathology of the lungs for atelectasis, giving sort of, you know, an intraoperative, post-operative thought, perhaps bleeding, and perhaps just the general inflammatory process that we have. So I suppose from those points of view, then actually we are more sensitive and observant for the possibilities of benchmarking before we start, optimizing before we start, and then actually making sure that RV function is monitored closely. And by that, we kind of, again, we need to make sure that the patient is well filled but not overfilled, that they are offloaded. And as John said, although that's quite a fast heart rate for the UK, I think that making sure that you've got adequate cardiac output by driving the patient, reducing acidosis, as I said earlier, are all prerequisites of managing right ventricular failure. And I would take you back to Christina's first observation. They are very different and they must be managed very differently as well. So.
Absolutely. And I think the other patient population at risk is those with right-sided valve dysfunction, like tricuspid valve disease patients. As we've seen more of those and more of our assist device patients, we've seen more of this. So I agree. I think it's a combination of us paying more attention to it and us having more patients that have right ventricular dysfunction vulnerability. I'd like to conclude with my last question and not get into a long discussion about devices, but just in general, it does seem like we're seeing a lot more of these devices in our unit. Impellas, ECMOs, VADs. And some balloon pumps. And so, John, you've already commented that you're seeing this in your center as well. Is this happening in the operating room? Is this happening before surgery? Do these devices get put in the ICU very often? When are these devices being added?
How about all of the above?
Okay.
Honestly, that really is our situation. Typically, ECMO is placed in the cath lab balloon pumps and Impellas are placed in cath lab under urgent conditions.
Okay.
Occasionally, we have a patient that struggled coming off pump in the OR that could come out on any one of those devices. And as we've become more comfortable with them, we have a lower threshold for using them. So in some ways, it's almost reassuring. It's a very double-edged sword with mechanical support. On the one hand, we're very relieved that we are on support already. Like the patient that's struggling with respiratory failure that hasn't been intubated yet, it's almost a relief when you have a secured airway and you can control them with mechanical ventilation. We look at this the same way in circulatory support. Um, the downside is the fact that they need it, and the fact that they need that level of support means they're very, very sick. So it's a very resource intense therapies,
Yes.
but
Yeah.
we're using them a lot now.
And Christina, I know you said that you're, not seeing a lot of these in your center, but just anticipation. I mean, I think that's an important lesson as well, is really looking at the types of patients that you're seeing and asking if you have the resources that that you anticipate they'll need. So I was hearing you do a pretty good preoperative assessment of that then to make sure you've eliminated those patients before you get into that situation.
I mean, we all seen that we've got a case that we end up in trouble for whatever reason, and we need ECMO. Our center doesn't have ECMO, so we have to beg someone else to transport. But as John said, this is our very resources. So you need a lot of people. And imagine if you on your own place when you have the system, you need lots of people to resource that machine. So imagine when you need to transfer the patient from theater to another center to have ECMO. The few times that we've seen this happening, we end up with the patient on bypass for a longer time, because by the time that you have a team to come into your hospital and put the cannulas, put him on ECMO, and then start the transfer, it's just a lot of manpower. So you really, really need to discuss your patients before. And we see balloon pumps. We use it intra-op. If we need it, we can, as Tara said before, we can get out of bypass or we're in trouble, so we can use them, and then we can win the patient a day or 2 days after in ITU. That's an easy kind of resource that you can use, and it give you a lot of help. I don't use Impella, but again, Impella, I think it's quite a nice tool as well. ECMO backed, it's not my experience. We don't have it. So when you're in trouble, you're in trouble.
Yeah.
And it's difficult to get out of that trouble.
There-
I will say, I mean, we all end up in trouble because this is cardiac surgery. We know it's complex cases. Our patients are getting more complex. So, but I think to prepare your patient before, it's essential.
And they have all these tools these days, but you're right. I think it just makes so much sense to just really, do a thoughtful review and make sure that you're doing the right operation on the right patient at the right time in the right place.
And it's not a lot of people. I mean, to have
Yeah.
someone on ECMO, it requires a lot of professionals. So
Yeah, very resource
not
intensive.
easy. It's not easy.
Tara, did you have anything to add to that?
Yes, a few comments. I mean, I think both John and Christina raised some really valid points. And I think the one thing that would come out of that would be that the manpower to manage and the facilities and the environment, you need to be confident that that's a 24-hour, 7-day service. So it's all very well having the manpower and all that goes with that in the daytime. But, a patient comes out of theatres late afternoon, it may well be the middle of the night that they run into. So have you got somebody who can do an echo or a tow? Have you got the ability to put somebody on a mechanical support, and just because it's there, in the building doesn't mean that you've got the infrastructure to do it. So as you say, that the sort of the checking of patients preoperatively and the strategic management plan and options to have during surgery and postoperatively are paramount. I think the whole emphasis around resting the heart that John brought up earlier and Christina's talked to in terms of intraoperative balloon pumps, preempting issues and going from a 1 to 1 to 1 to 2, weaning and removing is also important. And then I think, you know, if you are in a transplant center, then you're going to be much better set up to be able to do, you know, your RVAD, your LVAD, your ECMO, etc. And I think if we move it forward, actually, when we're looking to hopefully get these patients towards home, you know, in the UK, we are very keen that these patients, all our patients, go home on what we call secondary prevention in terms of triple therapy for a beta blocker, unless there's, you know, coexisting, contraindicating causes. Then you're going to do a beta blocker, you're going to do an ACE or an ARB, or you're going to do a statin. And then you need to start to look at, if there is a degree of failure, perhaps we would ask for a heart failure review, whether those patients need to go home on sildenafil, or if you think about your type 2 medication these days in terms of your SGLT2s, they are actually increasingly used in heart failure as well, just in terms of managing symptoms and managing control as well. So I think it's important to think about the mechanical device electively, in the emergency situation and the infrastructure around that, and then post-operatively and moving forward, what can we do to optimize this patient when they go home? Because we've done a large intervention of surgery and we don't want to leave them, you know, from a quality of life position in breathlessness, swollen ankles, etc., more than we need to. So and obviously we would always, you know, look towards the basic stuff of diuretics, etc. as well.
Well, thank you for taking us full circle from inserting an assist device in the ICU to discharging that patient with appropriate medications for heart failure. That is the full spectrum of what we are responsible for. Thank you. So last week, I asked you who would be the most likely person to reopen a chest in your unit at 2 a.m. And your answers included junior surgeons, APPs, basically whoever's in-house that has the skills to do this. I've also had questions posed to you about the best hand position for CPR, about blood products versus factors. We've talked about a lot of really fun things during this series that I hope are educational and informative for those who have tuned in. We will have one more event that I want to let everybody know about. This will be a live webinar with this panel, and we will be joined with the King of Cows, Joel Dunning himself. And this will happen on Tuesday, September 2nd at 12 o'clock Central Time. So if you are interested in participating live, bring your questions, bring your burning issues. You can find out more about this at ctsnet.org. That's ctsnet.org. We'll put that on the panel for you to see. So now it's time for us to conclude our summer series, ladies and gentlemen. We have had a blast. It has been incredibly fun to come into your homes and have this discussion with you for the last 5 sessions. We look forward to you joining us. Bring your shades to the next one. We'll see you on September 2nd. John, Tara, Christina, thank you. This has been wonderful. Enjoy.
Thank you, Jill, for everything you've done. And thanks to the panel members.